Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hi, I'm Annie Luetkemeyer, and I'm a professor of medicine at San Francisco General Hospital at University of California, San Francisco. Welcome to Clinical Clips in HIV. This is the first of our two conference highlights from IDWeek 2025 in Atlanta. And today we're going to cover October 19th and the first half of October 20th. Thank you for joining us. So I wanted to start first by talking about some novel antiretroviral combinations that are under investigation that I think there's a lot of enthusiasm about. So the first is a combination of doravirine and islatravir. And remember that this is a combination of an NNRTI and then the novel class of NRTTIs. So this is pooled 48-week data looking at the 051 and 052 studies. And just as a reminder, these were both switch studies, which randomized individuals either taking BIC, F-TAF, or standard of care antiretroviral therapy, and they were randomized to continue or to switch to investigational therapy with DOR islatravir. And this analysis looked at 48-week data and looked at viral load less than 50 copies. And I think reassuringly, what they found is that the viral loads less than 50 was really equivalent by investigational arm and standard of care arm, so roughly 93% in both. When they broke this down by female sex at birth, by gender at birth, females had similar viral suppression, so 94% in the investigational arm versus 90% in the standard of care arm. Same thing with males, 93 versus 94%. They saw no significant decline in CD4 cell count. Interestingly, they also found no significant change in weight, but I think what we've learned from the DO-IT ACTG study, which was released this summer at IAS, is that changing to a doravirine backbone, either with TDF or with TAF, really did not make a difference in terms of weight gain, and that was really a weight-neutral approach. And the same thing was found in this analysis when they found that a change to doravirine-based ART really did not make a difference in a statistically significant way. A second analysis looked at both the 051, 052, as well as 054 data, which is a protocol that captured individuals who'd rolled over from prior phase 3 studies. And this basically looked at virologic suppression in the setting of archived DNA resistance. And they had 90% of individuals who were enrolled had proviral DNA data that were available, and about a quarter of them had some NNRTI resistance available. So there were 43 individuals who had DOR RAMs. 2 of them had confirmed viremia, but they were found to be ineligible from the beginning, so they shouldn't have been enrolled. 4 had transient viremia and then resuppressed. And there were 8 individuals who had doravirine and M184V. And again, 1 of those individuals was ineligible, and 1 had transient viremia and suppressed. I think this adds to the growing body of literature that has made it a little murky what the role of proviral DNA is in clinical management. Certainly it does not seem to predict, at least in these data, doravirine or islatravir failure, so that's reassuring. But I think the role and the enthusiasm for proviral DNA in clinical management is really waning. So I want to move on now to talk about therapeutic approaches with lenacapavir, and we're going to have a number of abstracts to talk about over the course of IDWeek, but I'm going to start with twice-yearly lenacapavir given with 2 impossible-to-say monoclonal antibodies, so tirapavimib and zirnlirivimab, as far as we know, but I'm going to call them TAB and ZAB as they've been referred to. So this analysis looked at the pooled safety and tolerability data of this twice-yearly Len-Zab-Tab combination and went out through week 26, and it's a pooled analysis of the phase 1b as well as the phase 2 data. And it's important to understand how tolerable these injection-based antiretroviral combinations are, as we know that lenacapavir is a subcutaneous, at least in this study, given as 2 subcutaneous injections after an oral load. And it creates a subcutaneous depot that is the mechanism of action for releasing the drug over time. So first of all, only 5% had a grade 3 adverse event in the lenacapavir arm, and these were not attributed to the investigational agents, so that is good news. But we know that injection site reactions are common with lenacapavir-based therapy. So 65% of individuals reported an injection site reaction. 85% said that they were grade 1, and 33% reported a nodule, as to be expected, again, as I said, based on the mechanism of action. The nodules lasted a median of 246 days, so that's about 8 months. There were 13% developed anti-drug antibodies against TAB, and 18% developed anti-drug antibodies against ZAB. And this is after receiving one injection, as this is a 26-week analysis. Now, importantly, these were not associated with viremia or with failure of the regimens, so it remains to be seen if this would become more prevalent or clinically significant over time. However, at this point in time, after 26 weeks, while a minority of individuals did develop these anti-drug antibodies, they don't appear to be clinically significant, and they were low level. But this is something for us to keep an eye on over time as we learn more about this combination of lenacapavir given with 2 monoclonal antibodies. So I want to talk a little bit about lenacapavir in terms of its potential for drug-drug interactions. So one of the concerns is that lenacapavir is a moderate CYP3A inhibitor. So 2, I think, interesting abstracts that came out at IDWeek in Atlanta this week talk about potential for drug-drug interactions with 2 important classes. So the first is looking at the potential for interaction with long-acting contraception. So in the Purpose 1 study, which was conducted in women looking at lenacapavir for PrEP, many of the women were on injectable or implantable contraception, including medroxyprogesterone, so DMPA, another injectable norethindrone, or the implantable etanogestrel. And what they did is a PK sub-study looking at the levels of these hormonal contraceptives in the women who had received lenacapavir for HIV prevention. And what they found in looking over 48 weeks is that there really was not a meaningful change in the hormonal contraceptive levels. They did see a small bump in the levels of the etanogestrel, but these were not outside of what would be expected, and they did not see an increase in adverse events with that initial bump at week 13, and this evened out by week 48. So I think these are encouraging data to suggest that long-acting methods of contraception will be compatible with the use of lenacapavir despite this moderate CYP3A inhibition. So the second study the Purpose 2 study looked at lenacapavir for prevention in individuals who were randomized to take 1-to-1 to take lenacapavir versus FTDF for HIV prevention. And 22% of people in Purpose 2 were gender diverse, and we know that 11% of them reported being on gender-affirming hormonal therapy. So this was a sub-study that looked at 115 individuals who were on estradiol and 25 who were taking testosterone. And they looked at the impact of those in the lenacapavir arm to see what the impact on the gender-affirming hormonal therapy was. And they found no impact on estradiol levels and no impact on testosterone or plasma DHT, the active metabolite. Now, importantly, they didn't look at the impact of the FTDF on estradiol or testosterone or DHT concentrations, but this has been looked at in other studies, so those data are available. So I think that this is reassuring from both studies that lenacapavir, when given as PrEP twice yearly, can be given safely with commonly used injectable or implantable hormonal contraception, as well as with commonly used gender-affirming hormonal therapy. So the last study that I want to talk about today is the EMPOWER study, which I think addresses a really important question. So this study looked at individuals who'd been on cabotegravir, rilpivirine, in IM-ART, and chose to stop for whatever reason due to their provider or their own personal preference, but not virologic failure, and they switched to BIC-F-TAF, oral medication. And this followed them, a small group of people, about 33, for 24 weeks to see how they did. And I think reassuringly what they saw is that at week 24, 91% of people had virologic suppression. So there were 2 individuals who had missing values, and missing counted as failure. But when you looked at those who had virologic data available, 100% of those were suppressed. And this is a small group of people, and I think that we're eager to have more data, but I think it is reassuring that in patients who've made a decision that they want to switch back, as long as they don't have concern for drug resistance, and if they can take oral medications and that's what they're choosing to do, that this is a reasonable option to switch them back to an integrase-based regimen orally, and that we have every reason to think that they should stay suppressed as long as they're able to continue to take the medication regularly. And this helps us provide our patients with choice, which I think is really key to attaining virologic suppression. Thank you so much for joining our clinical clips in HIV. Please click Continue to complete a brief post-test and evaluation to claim your continuing education credit. And please be sure to come back tomorrow for part 2 as we wrap up some remaining terrific science from IDWeek 2025 in Atlanta.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and select Continue to move through the post-test and evaluation questions.